Okay, so moving right along. Now I would like to introduce our next representative, Dr. Nick Van Sickels from CrescentCare in New Orleans, Louisiana. Nick will be joining us online. Is he online now? Okay.
Yes, can you all hear me?
Okay.
Yep.
So Nick earned his degree from University of Kentucky in 2005. He's originally from San Antonio, Texas, and has been in New Orleans for 11 years. He went to the University of Texas at Austin for undergraduate training. After graduating, he moved to New Orleans, where he completed internal medicine training at Tulane, and he went on to be chief resident in internal medicine and then completed an infectious disease fellowship in 2011. Since then, he has been a faculty physician at Tulane and is now the chief medical officer of CrescentCare. Nick, thank you for joining us. Can you please provide a brief introduction to your philosophy of model care? And we would then like to prioritize an open discussion so that we can ask you questions from the committee. And we'll have to end this discussion at around 10:15. So we got about 45 minutes. So please go right along.
Sure. So I think it would help. I just want to start by saying we're a relatively new program, especially in terms of integrating substance use disorder, HIV care, hepatitis C treatment, and harm reduction. But I'll give a little bit of background about CrescentCare just to kind of help frame the discussion. So we started in 1983 as the New Orleans AIDS Task Force, an HIV service organization. And over the last 30 years, we've evolved to become an FQHC, and that was relatively recently in 2013, to provide gender-affirming care and dedicated gender clinics, to be one of the largest PrEP clinics in the state of Louisiana, and now to providing not only outpatient treatment to people suffering from substance use disorder in terms of therapy, but medication-assisted treatment, both on an addictions model and on a primary care model. So how we are structured is we are a team-based approach. We have a provider, nurse, and case management team that sees all of our patients. We do have physicians and nurse practitioners and PAs who predominantly see HIV, people living with HIV and other infectious diseases, as well as primary care providers who can do the same, but generally focus on primary care issues like chronic medical conditions, et cetera. Our addictions-based primary care team consists of 3 providers, 2 MDs and 1 NP, who work with a dedicated nurse coordinator. Our addictions team are 2 addiction-certified physicians who are both part-time, and we have a seamless referral process between the primary care base and them. There's really no difference based on HIV, but we do have an HIV, a provider who can provide antiretrovirals and hepatitis C treatment on all of those teams. We are relatively new at this. I will just tell you, we started with having syringe access in about 2013. Our syringe access program has grown substantially, and now we see about 250 clients a week and exchange over 700,000 needles a year. That was where we began. We got a HRSA, a SAMHSA rather, grant in 2016, started providing therapy. In 2017, started having addictions treatment. And finally, in 2019, we have addictions treatments with physicians in primary care, physicians in addiction medicine, and therapy coordinated with our syringe access program that has a clinic embedded in it to provide harm reduction, education about Suboxone, wound care, and seamless referrals for medication-assisted therapy, outpatient treatment, and outpatient intensive treatment. The one thing that's new, and the reason I told Andrew I was not going to be be able to have a formal presentation for this meeting, was our state. We are fortunate in our state of Louisiana to be a Medicaid expansion state in the Deep South. It has been of enormous benefit to us. One thing that Louisiana has struggled with is treatment of hepatitis C as part of comprehensive integrated care, especially for those with Medicaid. Really, honestly, we were only able to treat people with stage 3, stage 4 fibrosis who had Medicaid, and recently we could treat them if they were living with HIV as well. Just Wednesday, our Secretary, Dr. Gee, was able to sign and announce a deal with the subsidiary of Gilead, Sickels Pharmaceuticals, that we now will have a subscription model to treat hepatitis C, which is very exciting for us, and we'll treat all of our patients, about 39,000 who have Medicaid or who are incarcerated in Department of Corrections facilities. That was really one of the biggest pieces we were missing in kind of the integrated care, was to be able to do the harm reduction, do the syringe access, do the Suboxone or other medication-assisted therapy, do the therapy, do the HIV treatment prep, but we couldn't treat Hep C. Now we can, and it's a big advancement. But this all came together very quickly. There was a lot of planning, of course, on the state's part, but the lead up and the announcement happened kind of quickly just because of various deal things that I don't understand. And so we've furiously been trying to get our protocols ready, because we're going to be able to prescribe generic Epclusa or soft Velpat on July 15th to anybody with Medicaid. So we are aggressively ramping up our services, and that's what I've been diving deep in the last several days. So that's the introduction to our program. I think I might be best served by answering some questions or discussing a little bit more with you some of the barriers and challenges we've faced. And I can't emphasize enough, we're a very nascent program. You know, our primary care model for substance use treatment started in May. So, you know, we're learning as we go.
That's terrific. I appreciate that. I think we're going to go ahead and start asking some questions, and I will start just by saying, you know, tell us a little bit about how you see the, you know, how do you integrate into your program a sort of harm reduction culture, and how do you see that happening, and how do you make it happen?
Yeah, so that took a long time. It's an excellent question. I was fortunate to be able to hear the last speaker discuss a little bit of what he has done or his program has done, and actually going to shamelessly steal some of that and suggest, especially having people from the community do some of the interviews, because it was a challenge for us when we got the SAMHSA grant, especially. And just to give you a little background about CrescentCare, we were separated into different locations. And so our syringe access program was at a site near the French Quarter of New Orleans, and our substance use program was about 1.5 miles away. Now we have co-located, and we are in one neighborhood that is a hot spot for people who inject drugs. And so it's a great location, but it really kind of forced us to marry these two kind of belief structures. And when we started our substance use treatment, we were just kind of scrambling to hire people. And our approach was rather antiquated, and it was not harm reduction focused. It was, I don't like the word punitive, but it was, you know, if you don't make your meeting, you can't get your drug. If you don't make, you know, this, you're going to be out of group. And it took a lot of collaborative meetings, especially with the people who work in our syringe access program. And to be quite honest with you, they are the reason we have a harm reduction approach, because they are the ones who are in the community, who have buy-in with the community here in New Orleans to really tell us what it's like. You know, I think in group and when we see patients in clinic, you know, me included, you know, we get a small picture of it. They are there every day out in the community doing testing, doing outreach, training people on, you know, proper water use, proper cotton, proper injection technique, et cetera, and have tons of buy-in. And having them at the table and really just repeatedly going over it, honestly, it took about 4 to 6 months, and getting our primary care providers on board, who were very, you know, in some ways hadn't been clouded by some of that older kind of ways of thinking, helped us change the culture. And our addiction providers, all of them eventually got on board, and we've changed our entire messaging. We changed our entire script. We encourage people to go to group. We encourage people to go to, you know, any kind of meetings as an adjunct for support. But there's no consequence. There's no penalty. There's no nothing. And really, we want to focus on just meeting patients where they're at. You know, and I think it's a lot of discussions, and it's still discussion ongoing. You know, if people are still using heroin, you know, it took us a while to say, like, well, they're using once a week now. That's great. Let's just keep going. And we talk to them about it a lot more, and really try not to punish them at all. And that's the goal, and I think it is being realized finally. And getting feedback from that community every Friday. And as I mentioned before, we embedded a provider and our wound care and Suboxone nurse in that clinic. That also has given us the buy-in. And it took, you know, our finance division did not enjoy this, but the first probably month and a half of having an embedded clinic, they saw maybe one patient a week because the patients didn't want to sign up. They didn't want to sign the FQHC paperwork. They were like, who is that? And that really also bridged the gap. And now they're seeing a lot more patients. They're much more willing to see us and talk to our nurses and engage more in our health center. So that's kind of been our journey. I hope that helps answer the question. It was a little bit organic and pieced together, but I think really was driven by the community and by the advocates.
That was great, very much so. Before we open to the panel, let me just ask one additional thing. I was trying to check it here, but you could tell me. You guys are not a Medicaid expanded state, right?
No, we are a Medicaid
You are,
expanded.
okay.
Yes,
Okay.
we expanded in 2016 with Governor Edwards.
Okay, good, terrific. Well, that's good to hear. Congratulations. Dr. Springer, you go ahead.
Hi, thank you. This is Sandy. So I guess I was going to just build off of the Medicaid. So it sounds, I don't want to put words into your mouth, but without Medicaid, a lot of these services would not have been available for these patients, correct?
That is correct. We are able to, we've actually done, now that we've had several years of Medicaid expansion and aggressive enrollment in Medicaid, the clients coming through our syringe access program, over 50% of them are actually already enrolled in Medicaid. Mm-hmm. And they just, in May of this year, lifted the prior authorization requirement for buprenorphine for all the Medicaid plans in Louisiana. So that is another barrier that was lifted just this year for us to be able to provide medication-assisted therapy. And one other thing that just got changed, and I heard the last speaker mention this in April this year, is they have removed the one visit per day requirement, and that took a lot of lobbying from our primary care association here in Louisiana. But after 3 years, they removed it. So people can see the behavioral health provider, and they can see me, or they can see a primary care provider and have a dedicated, BUP visit or an HIV visit or whatever all in the same day, and we can still bill at our health centers in Louisiana. So I would agree with you 100%. Medicaid expansion has been just very wonderful for us in Louisiana.
That's great. Really wonderful to hear that. I have some other barriers. So if you, it sounds like you wrote in, or what's been written in this document is that the X waiver is burdensome and difficult and lack of financial support to help your providers get BUP waivered. Do you believe that this waiver is necessary, or what are your thoughts about removing the X waiver?
The waiver creates an unnecessary barrier, in my opinion. I am one of the providers who does the BUP clinic, and so I got my waiver last October. I did the IDSA half and half training, which was great. And I'm limited to 30. And I tried to write SAMHSA and get my waiver, extended early, but I have to wait till October to treat 100 patients. And I mean, I'm preaching to the crowd here. I mean, we are in an opioid epidemic. There's no way I can just see 30 patients. And this is a half day a week that I'm working with other providers. And they are coming. There are so many of them. And I prescribe so many other medications, Schedule II medications, without a waiver. I think training is important because it helps us. I appreciate the training just like I appreciate any training because it's a learning experience. But the waiver is an unnecessary barrier, and I would just argue in this day and age with the epidemic going on, it is not helping us to expand efforts. And more of our primary care providers at CrescentCare want to be able to provide Suboxone to their patients, especially the stable ones. And pigeonholing those patients back into a Suboxone clinic or a BUP clinic, rather, it just, again, creates an unnecessary barrier, and I think it should be lifted. That's my opinion.
Thank you. And my last question is the criminal justice system. You had written here that patients' perceptions that police are frequently arresting them for possession of drug paraphernalia has been a burden and a barrier for your patients accessing treatment. What what are your thoughts, or what is your current arrangement, or do you help individuals coming in and out of the correctional system, probation, parole, and how are you decreasing that perception, or is it really in fact an issue still there?
I mean, Louisiana is, and it's no secret, we have a problem in our state with incarceration. It has gotten better, but it is, used to be one of the highest incarcerated states in the nation. I believe it still is, but if not in the top. I think one of our, again, if we didn't have the syringe access program embedded in our clinic, I don't know if we'd have the trust of the community to come to our clinic. Where our clinic is located is a high crime area, so there's a lot of police presence, which we were very worried about with our patients, that they would fear coming in because they would fear being arrested. It's been quite a balance to balance safety and feelings of safety with our staff, with also not overwhelming patients by having police presence in the or around the health center. It's a very delicate balance. I think still a lot of work needs to be done. We focus on educating the patients about coming in, places to go that are safe. I mean, it is still very much a problem, I guess, to simply answer your question.
Thank you.
So we did the buprenorphine training together. This
Yes.
is Carlos. And I'm glad we took the initiative then. So, Ellen, you want to say something?
Hey, this is Ellen Eaton from
But it wasn't a lot of people.
UAB. Thank you for your time.
pretty empty.
I know that a lot of great work is being done in your area around STDs, and I'm curious if sexual health is being integrated, and specifically PrEP as well, into some of the services that are provided on site.
Yes, it is. That's a great question. So we have two ways of doing this. One, we're very fortunate. We are partnered with the LSU Sexual Wellness Center. They're actually embedded in we have two main sites in one of our sites. And they are now, they do comprehensive screening and treatment. And then they refer to us for PrEP, for Suboxone, for Rapid Start, for rapid reentry, for anything with coordination of HIV, Hep C, or prevention of those diseases, and treatment of substance use disorder seamlessly. They just send them downstairs and we see them. It's quite nice, and we're able to do that the same day in almost all cases. At our site where we have the syringe access program is actually our prevention division. We do everyday rapid HIV, HCV, and syphilis testing. And then we also have comprehensive testing through wellness grants for, unfortunately, certain demographics only, but for STIs. We are because Louisiana is so highly ranked, especially New Orleans, for syphilis, gonorrhea, and chlamydia, are usually in the top three. All of our providers do triple site and aggressive STI screening. And right now, we're very fortunate that our Medicaid program, and I feel terrible saying this because you're in Alabama and I wish you had Medicaid expansion, but we do aggressive triple site screening. Medicaid does cover PrEP, PEP, and all antiretrovirals. And now this week, starting July 15th, we'll cover Hep C treatment. So we're very lucky in a lot of ways of how our program has evolved in the state over the last 3 years.
Thanks. One follow-up question. I know even with Medicaid, a lot of our homeless patients have unique challenges keeping up the documentation required to maintain their insurance through Medicaid and other insurers. Has that been have you seen that impacting your patients' lapses in care, lapses in PrEP or other prescriptions, or has that not been so much of a problem?
No, it's definitely been a problem. And as much as I've applauded Medicaid, when they started Medicaid expansion here, it was pretty simple to get Medicaid, and they've changed the computer system that does a lot more income and other verifications. And they're sending letters out to patients that they need to respond to in order to stay on their Medicaid or ensure it's renewed appropriately. Unfortunately, and again, I'm this is an obvious statement, but if you are homeless or you are not able to check your mail on a regular basis, you lose your Medicaid. And so what we've done is just had signs posted. We have eligibility specialists and one insurance. She's a counselor and a social worker, but focuses on insurance enrollment and eligibility to help the clients re-enroll, go through the process. But yes, we've seen a definite effect, especially in the last several months. A lot of our patients have lost their Medicaid access, mainly because the way the state has communicated is mainly through letters, and the patients aren't able to receive them, and that's been one of our barriers. We've actually applied for and asked the state to fund, so we'll see about that, a Medicaid outpost in our health center. It's actually not terribly expensive. So, I mean, if they say no, we'll pay for it probably, but the way our Medicaid computer system works, unfortunately, they won't give us a determination within a very short period of time. It takes about 3 to 4 weeks to find out if somebody is re-enrolled or is active again. If we had a Medicaid outpost in our health center, we could get that within a day, and that way we get a claims or denial letter. And if there's a denial letter, we can work on other assistance programs to get people their meds, whether it be through Ryan White, patient assistance, et cetera. But yes, it is a problem in our state.
So thank you. I think that's the first integration of a Medicare outpost we've heard from all of the integrative and novel approaches so far. Thanks for your time.
No problem. Well, cross my fingers. They're coming mid-July for a site visit, and I'm hoping to dabble with it still, but I think it'll help us, and it'll help our patients.
David?
Thanks very much. This is Dave Thomas, Nick. And I wonder, I was just going to tunnel in a bit on the methadone treatment and ask you to what extent you see you're partnering with methadone treatment in New Orleans, to what extent you your patients would be better off if you could prescribe your own methadone, and then how do you envision reciprocally taking care of the infectious disease needs of those who are in methadone already, but perhaps not your patients?
Sure. So we currently don't prescribe. We're not a methadone facility. The people who refer to us, if they so our SAMHSA funded program and any of our services really are open. And when there is somebody who requests methadone, or who the way our system works, we designed it kind of in terms of medication assisted treatment is a kind of an internal spoke and hub model. So the primary care providers, we will see people. We see anybody, but if there's somebody who has severe addictions needs, is using multiple substances, high levels of benzos, specifically request Wtex if they're not pregnant, or methadone, we have them see our addiction certified provider, and then they will partner with one of the methadone clinics here in town, especially if they get above 24 milligrams of buprenorphine. That's where we usually will also refer and partner with a methadone center. We still see them for primary care. We have always been a referral hub for hepatitis C, for PrEP. We're the largest PrEP provider in New Orleans, and for HIV treatment. So, I mean, we see anybody, and especially now with this new program to treat people with Hep C, we're trying to get everybody treated the minute they walk in the door. So I guess I don't have the best system worked out, but if people call for Hep C, we have slots 2 to 3 times a week. We will get them in, if not that day, to see and treat their Hep C once July 15th comes around and we're able to provide the drug.
How's the transportation work between places, and what's your sense of the loss of people from referral to both when you refer them for methadone and when they send them back, as opposed to a model where you might move the ID care and or methadone care to where the patient already is?
Yeah, no, it's a huge barrier. New Orleans has, our buses are, our transportation, our public transportation is not the best. Medicaid transportation is probably similar to many other states. It is okay if you have Medicaid. They're often late. The patients complain about it. There's long waits. If they have or are eligible for Ryan White services, we can use ride sharing if the Medicaid transportation is over 10 minutes late. So that's one advantage, but unfortunately that only applies to Ryan White eligible clients. I certainly am more than open to, and we've discussed methadone. We just, at this point, given the relative newness of our integrated program with just doing primary care-based buprenorphine, we're not there yet, to be completely honest with you. And that's where we decided to start, just because of the relative ease, even though I complained about the training a little bit, but the relative ease of starting buprenorphine and providing that service. And it is the most recommended service. But yes, I agree with you 100%. If we could provide methadone on site, it would be a significant benefit to definitely a subset of our population, especially given our location in New Orleans. We are really in two very prominent areas for people who are suffering from addiction.
Final follow-up question has to do with the, you said that you've solved the two encounters in one day problem. I thought that was a Medicare federal issue. Is that a state-by-state Medicaid? So tell me more about how you solve that and how you understand that to work. Because others have had that same issue, including Dr. Basitis, who spoke before you.
I didn't solve that, just to be clear. Our Louisiana Primary Care Association lobbied the state Medicaid program. And to be honest, I haven't looked into inpatient, whether that is applicable. But what it specifically will allow us to do is have a primary care visit and a specialty visit, such as OBGYN, dental, and behavioral health on the same day. I'll have to read over the document because I really focus, because I'm outpatient focused on the outpatient setting. I don't know how that extends to other environments, but for FQHCs in Louisiana after April 1st, we are now able to bill for those two visits on the same day for Medicaid patients. That is something that the state was able to grant for us. I'm happy to share you the announcement. I can email it to you.
Actually, that would be great, and I can follow up with Dr. Gee to see how that, because I think I'm curious whether your state solved that federally or whether it's somehow been sorted out locally, because it would have implications into what we recommend for integration of care. It's a consistent obstacle, so thanks a lot for that.
Yeah. But yes, all credit goes to our primary care association in the state of Louisiana. They are the ones that had really taken a lot of the feedback from the health centers and brought it to the state. So I'll send that to you as soon as we're done.
Just a comment. It sounds like the state got an 1115A waiver. Yeah.
Well, this is really exciting work you're doing. I have a couple of questions. It seems like there was a transformation, and part of that was understanding, sort of meeting people where they're at in terms of their addiction. And would you characterize that as becoming sort of more patient-centered? We're hearing a number of programs where they sort of, the patient remains the focus, and the different specialties and services kind of cluster around the patient rather than the patient having to go different sites.
100%. I mean, I think this definitely came from a patient-focused approach. I mean, yes, that was the simple truth. And I think having us meet with people who are around that community and not just in that isolated setting, and again, bring us all together. I think when we were separated by different sites, it just, it was very easy to say, oh, okay, that approach makes sense, to maybe create these barriers or create these boundaries with the patients. And certainly I believe in some boundaries, but I think our overall approach is very centered on the patient and on the advocates communicating very well to us what the patients are expressing that they might not express to a physician or a provider or a therapist,
Great. The other thing that we're seeing a lot of is that not only Medicaid expansion, but Ryan White funding seems to sort of encourage and facilitate innovative approaches to addressing patients. Would you say that your Ryan White funding has been helpful
Yes, definitely. We probably, and I'm trying to, as you were saying that, I was trying to just think quickly on specific instances. To be honest, it has. We've benefited so much more from the changes in Medicaid, especially the lifting of the prior authorization. I mean, that was huge for us as a barrier to providing buprenorphine. For Ryan White, I know we were able to get, before that was there, we were able to use our formulary in our state, I believe, for bup when people didn't have coverage. But yes, I would argue it has. I'm just thinking about, let me come back to it and think of any specific examples, but certainly it has in terms of providing all the wraparound services, housing, other behavioral health access, case management access. We have case management for our non-Ryan White clients, but it certainly is a little bit more intensive for Ryan White focused, or for Ryan White fund eligible clients as well. So all of that support certainly does benefit the clients who are suffering with addiction.
Great. And then finally, I want to talk a little more about transitions of patients with both with sort of acute, subacute infections in the hospital, and also just patients who are incarcerated transitioning out. Are you able to get people started on MAT inside corrections, or continued on MAT in corrections, or pick them up promptly after transitioning out, and also from the hospital?
Yeah, corrections, yes. So in New Orleans, we have there's a really phenomenal physician advocate, Dr. Anjali Niyogi, who started what's called the FIT clinic, the formerly incarcerated in transition clinic. It works out of one of the FQHCs, the Healthcare for the Homeless here in New Orleans. What they serve as is a transitional hub so our DOC, when the DOC inmates are released, they get Medicaid upon release. They're still working on that for the parish jails. They will go to the FIT clinic in most cases here in New Orleans, or to a clinic in other parts of the state. But in New Orleans, I could speak to what goes on. And then she will get them plugged into most commonly an FQHC, but also another health center in their neighborhood that takes Medicaid. If they need substance use treatment, Healthcare for the Homeless is able to provide it that day. We are able to provide it that day, and they are starting Suboxone on a lot of the patients in the hospital. The internists and the ERs are all able to provide it as an inpatient, but a lot of them also have their X waivers to write for it for a short course till they can get to us for a follow-up. And we structured our primary care-based clinic so that we could see people within 2 to 4 days of discharge from the hospital always. Certainly at some point we're going to be at capacity, but my hope is we'll keep building.
Great. Thank you.
Hey, this is Hannah. Thank you so much. I wanted to just have a quick follow-up on the prior authorization discussion and then ask kind of a meatier question. So for prior authorization, I understand that you got that waived for buprenorphine. Does that waiver extend to implants?
It does not. And it only is, so it's tricky. It's the films only, which most of the patients I find prefer anyway, over the tablets. And it's you can only write. They'll only cover 2 films a day. So we have to make sure the pharmacy, if they're on 16, you can do the 8-2s. If they need 24, you have to go 12-3, and the pharmacies often don't have that. So it's one of the small glitches that we've had, but it's not a big deal. We can overcome that. And and it does not cover the implant, no.
Got it. Okay, thanks. My kind of bigger question is, are you thinking about ways to deepen the integration between treatment for opioid use disorder and treatment and prevention of infectious diseases? And if so, are there particular policies that might stand in the way of kind of deepening that integration?
And so you're talking about it at our agency.
Yeah.
I mean, so our goal is to, as much as is possible, one, we're a large agency. We have 300 staff, and we have about 12,000, 13,000 patients. So we're pretty big, but not that big. So we're still able to pretty easily integrate just in terms of face-to-face communication and visits. But we try now, especially with this Medicaid rule change, see patients the same day from multiple services for integration. And we also try to, with the success of our Rapid Start for HIV program, we've now, after lots of hoops and talking with the city, a rapid reentry program. We're going to be doing Hep C the same day. We're trying to do everything as much as we can when the patient is there in front of us to integrate. As much as providing centralized, from kind of a broader programmatic standpoint, we have not yet, though we are soon going to start having kind of the MDM type meetings where we can really help coordinate the patients and bring the navigators and the kind of nurse coordinators together to really focus on these patients, but we're not quite there yet, to answer your question. But yes, that is definitely something we're looking at and something we need to do, because otherwise we won't succeed.
Are there any policies that you can foresee that might kind of get in the way of those plans?
Locally, I mean, certainly the stuff that is a constant barrier, as was already discussed, transportation, as was discussed, some of the barriers to obtaining an X waiver. The big thing I fear is that we're going to keep getting more and more and more and not have enough providers or capacity. Right now we do. In terms of statewide or political policies, I mean, I certainly always fear for what is going to happen in our healthcare environment. Louisiana is looking at a more value-based model for 2020. I'm not sure how that is going to affect all of this. And that's definitely one of the bigger fears I have. Not necessarily bad. I'm not saying anything against it right now. We don't have enough details on how exactly it would work. And what that might cause in terms of a frame shift of how we're doing things now. So that is one of my potential fears, but one that I probably can't speak in an educated way on right now.
Thanks so much.
Dr. Springer?
Oh, thank you. So this is Sandy. A couple of questions. So do you have any data? I know you just started December of 2018 integrating buprenorphine into your program, but do you have any data about retention on buprenorphine in your program, like the percentage who are on treatment at, say, 3-4 months out?
Yes, but not off the top of my head right now.
Okay.
And then, I do, yeah.
That's okay. The other thought is, I know Hannah just mentioned Probufene, the implant. I would assume you probably have similar issues regarding the injectable buprenorphine sublocade.
Right.
And so you haven't started that. What are your thoughts about an injectable medication that lasts over 30 days, about these issues of taking medications? So there's also extended release naltrexone and now sublocade in terms of helping people stay on treatment.
Yeah, no, we actually do it. Our addiction providers do it if they can get it approved, depending on the insurance plan that the patient has. Yes, I think it's a needed adjunct to treatment. I mean, just like I'm excited for injectables for HIV, for PrEP. I don't think they're going to be for everybody, but I think some people will strongly benefit from it because they don't remember or don't like to take a daily medication, or they don't like how the film tastes or how it absorbs, or if they're on the tablets or whatever the case is. I think injectables are a great option for people, and I would love to expand those.
Are they covered by your state Medicaid?
No.
Okay.
I have not. I have, to my knowledge, I'd have to ask Dr. Carr. He's one of our addiction specialists. I do not believe. I'd have to see. They've changed everything since May 1st. I don't.
Okay. That's okay. I was just curious because they are very expensive. Here's a question. So we have a chart. So that in this country, we're to end AIDS, right? End HIV. We have a charge to do so. UN AIDS goals by next year that 90% of all people living with HIV are going to have viral suppression. Yet in this country, we're seeing, at least that we know of, over half a dozen new HIV epidemics occurring in people who are using drugs. and not just associated with injecting, but also new infections happening among women through heterosexual exposure in the setting of exchange sex for drugs. What are your thoughts about how, if we are going to end HIV in this country, new infections, with the ability to expand and address opiate use disorder medication treatment like buprenorphine in several settings, including states that don't have access to Medicaid or paying for these medications?
Yeah, that's difficult. I mean, even in our state where we have access to it, we still have trouble. You look at our PrEP population, and then you look at the population in our rapid start or our rapid reentry or our reentry and our retention cohort, and our viral suppression rates are high at CrescentCare. I mean, but we're not at 90%. We're at about 88%. And if you look at who we're serving with PrEP, it's not the population that we're seeing that's newly infected. I mean, we're doing better than maybe some other areas, but we're still not penetrating the community. And I mean, I think what you're asking is a larger policy question, and maybe I'm misunderstanding, but it's tough. I mean, the one thing that I think we are doing that I am proud of, that our agency does, is that we do so much testing and so much education, and we have two groups, our Trans Advisory Committee and our Black Leadership Advisory Committee, that go out to the community and actually specifically educate in areas of New Orleans, those communities you spoke about, heterosexual women, women of color, and people who inject drugs, about PrEP, about hepatitis C, about HIV, and about how it doesn't just affect, men who have sex with men, gay men, et cetera, which are, certainly still affected by the infection, but don't represent all of the new infections. That is what we are doing in New Orleans, is trying to expand our outreach and capture a lot of those populations, because we've done pretty well at capturing, not perfectly, we could do better, but done pretty well at capturing the group that was already going to come into care that we could easily get through the regular outreach in the local area around our health centers. Certainly I am very for Medicaid expansion, and I hope that in 2020 we will have an administration that supports better healthcare access for all in our country, especially those in the Deep South, who often, outside of Louisiana, there aren't any other states to have Medicaid access for the population. I don't know if I'm answering the question very well, to be honest with you, but that is what we are doing.
Okay, Dr. Chapman, you got the last question.
Yes, we have 5 action steps, and the fourth really deals with stigma in the not only in the medical community directly, but also indirectly. Do you think that it would be of benefit to upstream have training for sociology, psychologists, schools of divinity, criminology, in terms of really changing that dynamic?
Yes, certainly, and I think it could be extended to healthcare professionals as well. We in our citywide planning committee for ending the epidemic, one of the largest groups, and this is one brought by our planning council, is stigma. And one of the largest advocates in our city who is on that committee spoke up and said, what really frustrates me is I have all of these friends, all these straight white friends on the 610 Stompers, on all these groups in New Orleans, who all embrace U equals U and other messaging to support ending stigma. But then I go to the health centers and I have trouble with the providers, and it makes me crazy. So I agree with you, and would agree more that all of us in healthcare could certainly use more stigma and harm reduction-based education as well.
And one last question. Do you think the 16 milligram, 24 milligram dosage in the face of fentanyl, which to my way of thinking, we may be seeing a Darwinian effect of survivors who are actually ultra-rapid metabolizers, who may need higher doses of buprenorphine.
Yes, definitely, and that's where we in primary care have put a cutoff for people that have come in and are really not doing well on 24. I have them see our addiction providers, and we do have them sometimes go up to higher doses of buprenorphine or refer them to methadone access sites. But yes, I agree with you. And that's how we've shaped our program to address some of the people who have heavy addiction with some of the more potent opioids like fentanyl or carfentanil.
Well, thank you. That was really good. And I guess, I'll just end by saying, Dr. Redfield, the director of CDC, says that stigma is the enemy of public health. And I think you've put it right on, that exactly is the issue. We can have all these tools, but if we don't address stigma, we can't use them. Is there anything, we have like 1 more minute or 2 more minutes, is there anything else you would like to tell us, anything else that you think we as a committee need to pay attention to as we write this report?
The biggest things I think you all asked me, and I really appreciate, I think for us, if we could have easier access to being able to prescribe buprenorphine, I think that would be a significant benefit to helping treat this. I agree 100% with what you just said, and the last question about stigma, training, and education, and looking at a harm reduction approach. And I really think integration of services, as well as providing services like Rapid Start, like bringing Hep C or needle access to the patient in a co-located setting, is just, at least as we've seen so far, and I said this from the beginning, we're a nascent program, and we are growing in terms of this type of coordination. But we've done it well with HIV, we've done it well with coordinated diabetes care, and I think we will do it well with this. And so it is, that's the biggest thing I would suggest. But my biggest ask would be for the waiver.
Okay. You're not the first one to ask for that, so thank you very much. I appreciate you joining us, and you're welcome to remain online, or you're welcome to, if we need to, we'll get back to you at some later point. Thank you, Nick, very much.
Well, thank you all. I apologize I wasn't really able to answer all the questions as well as you might want. We are relatively new, but I appreciate you taking the time to listen to us, and any advice you can offer. We are growing, and we are so happy to learn from the rest of the community who's doing so well.
Well, hopefully this report not only will make recommendations, but will also help programs learn from each other, and I think that's a useful thing to have happen out of this.
Yep.
So we're going to take a 15-minute break, stretch, go to the restroom, and we'll see you promptly here at 10:30 to hear LifeSpring Health Systems discussion. Thank you.